So it's my pleasure to introduce Professor Andrew Argent, that is the director of the Pediatric Intensive Care Unit at the Red Cross Hospital, General Hospital in Cape Town. But I think above anything else is somebody who dedicated his academic and professional life to critically ill children with a specific focus on integrated approach in low-income countries. And I think you have a very, very peculiar position to talk us about children that are roughly the same kind of population we see in our settings, but from a high-resource setting perspective. So Andrew is going to talk about practical approach on sepsis, severe dehydration, anemia in his experience. Thank you very much.
Well, thank you very much for that introduction, and thank you for having me here. It's an extraordinary honor to be here in an extraordinary, beautiful city, so thank you. So you'll notice that I've cut part of that title off my title because I'm going to struggle to really move on to practical implications, and I'm going to start talking about the management of these three conditions of sepsis, severe dehydration, and severe anemia. And again, it's important to note that I come from this context, from Cape Town, from a hospital that looks like that, and has a huge amount of resources available to it. I perhaps do have some benefit in that many of the patients we treat have conditions that are very similar to patients in the MSF environment, patients with severe dehydration. I don't see patients with severe malaria, sickle cell disease, and those sorts of things. So some of that experience is actually not part of mine. I think before I get into it, I think there are a couple of background issues that I really need to touch on. And putting several topics together is important because although we're talking about shock, what you're actually doing is treating these patients in the context of services that are treating many other patients. And it's much easier in general to provide a superb service if patients are kind enough to come nicely categorized with the same disease process and uniformity. But the reality is we're dealing with a wide range of conditions. I think if there's anything that's come out over the last few days is that when we talk about shock, it's actually a complex process. And part of the dilemma that we're being faced with is you have a complex process, and now you want simple answers. And I'm not sure that you can give simple answers. And I think to put another feature in there is shock is not a single event that happens in isolation. Shock is part of a continuum of a disease process. And some children got there very quickly. Some children got there very slowly. I know that in our setting, children who get into critical care have often been sick for days to weeks before they get there. And their response to illness may be totally different to children who got sick this morning. And that's sometimes the picture you see with meningococcal disease. And so I think there's a wide range. And finally, in the context, not every treatment is equal everywhere, and I'll touch it on blood products. But the blood products that you get in North America to give to your patients in the ICU are not necessarily the same as the blood products you're getting in Niger, if you can get them. And I think we need to keep those issues in mind. And so what I'm going to touch on is something about the physiology and then move through to possibly some thoughts of being pragmatic. So what do we think about? I mean, with all the debate as to how you clinically define shock, most textbooks would agree that the issue is you're not delivering oxygen to the tissues. And the problem is when you start looking at oxygen delivery to the tissues, as this diagram shows you to some extent, is that delivery of oxygen to the tissues relates to things like your PO2, your oxygen content, your hemoglobin, and your cardiac output. And all of those things may differ. Part of our approach to therapy is saying, well, if I can fix those, then patients will get better. But part of the problem is that some of our assumptions are wrong. And if you look at most of the textbooks, they will tell you that in pediatric septic shock, what you have is low cardiac output. Well, there's increasing evidence coming from many parts of the world, including India from Sujitra Ranjit and others, that actually there's a whole range of hemodynamics in patients with septic shock. Some have high cardiac output, some have low cardiac output. And if our basic assumption is not right, well, maybe the idea of increasing cardiac output as our main approach may be wrong. Here's some very old physiology. If we look at cardiovascular systems and you talk about cardiac output, we'll talk about stroke volume, heart rate, and we'll talk about systolic pressures and how the heart functions. And yet, a large part of the circulation actually sits on the venous side. And this is some very old data from Guyton showing that actually some 35% of blood volume sits on the venous side, not in the arterial side. And if you ignore the venous side of the physiology, you may be getting the wrong idea. We talk about increasing cardiac function to increase cardiac output, but probably as important is that the cardiac output is related to how much blood comes back to the heart, not just how the heart functions. And so we start looking at different views of physiology. And here's just a diagram showing on the top right, you can see the arterial circulation coming into the capillary bed, dropping into the venous sump. And that venous sump leaves at point vein R into the heart. And the pressure there is the central venous pressure. Now what you can see is if that sump were suddenly to increase in volume, well, very little blood might get back to the heart. Increasing the volume might help. But if you put more volume into that, and the CVP went up at the same time that you put the volume in, well, actually the driving pressure to reduce blood back to the heart may not improve. So actually, the response to a bolus of fluid depends on a whole set of interactions of curves of venous function, of cardiac function, of Starling curves and so on, and it's a lot more complex than we thought and may not be the same in every patient. But it gets worse because we talk about oxygen delivery, we talk about blood content and cardiac output, but that doesn't tell you what happens at the tissue level. And you could be pumping huge amounts of blood through to the tissue, but if the capillary beds aren't actually working properly, and there's things going on at mitochondrial thing, improving the cardiac output may not have the effect that you want. And when you come down to the hemoglobin level, there's actually a very complex interaction between oxygen content, the release of nitric oxide, vasodilatation, which is part of the body's delicate systems to make sure that oxygen gets delivered primarily to the areas that need it. And unfortunately, disease processes that go screwball. So part of the challenge is that in a lot of situations, we haven't actually thought through the complexity of it. I just want to put this up again just to make the point that when you talk about the management of cardiac arrest by contrast seems such a simple condition. It's absolutely clear when it starts, when it stops. The heart stops, that's it. But if you look at the management of it, it's deeply affected by all the events that happened, and actually all the events that happen over the succeeding 48 hours, 1 week, and beyond it. And again, what we seem to be doing is focusing on what I do when I've got the shock child in front of me, and can I give a bolus now? Instead of saying, what I actually want to do is to change the trajectory from going down to going up. I don't have to fix him. I don't have to get the physiology right now. I need to get it trending in the right direction. And in a sense, what the control group in FEAST did, they were not getting no therapy, they were getting fluid therapy over a gradual period together with antibiotics and other items that they need. So that's something about the cardiovascular physiology that one puts into it. And I want to then move on to talk more about the issue of something about boluses in dehydration and oxygen delivery. So I don't think anyone would argue that if a patient is hypovolemic because they have lost a huge amount of fluid, be that in diarrhea and so on, I don't think anyone's arguing that we shouldn't be giving those patients fluid. And I think it's important just to reiterate, if you think they're dehydrated and hypovolemic, they need quite a lot of fluid, quite how quickly we need to give that bolus, I think, remains something to be discussed. What is also very important to pick up from all the literature coming out of the developed world is that giving too much fluid in virtually every situation, you look at it in the ICU, is associated with worse outcomes in some way or another. So giving too much of this stuff is bad news. It's also worth pointing out that we speak very loosely about hypovolemia and dehydration. And if you think about it, 5% dehydration means that you've lost 5% of your body weight, or 5 grams per 100 grams, which is the same as 50 mils per kilo. But if you were to lose that volume rapidly out of your intravascular system into the gut, you only need to lose 20 mils per kilo to be shocked. So we do need to understand the physiology that you can be dehydrated and not shocked. You could be hypovolemic and not dehydrated. And if you look at patients with nephrotic syndrome, it's possible to be overhydrated and intravascularly hypovolemic. And we need to think a little bit of how we unpack those and look at the separate clinical signs. I'm just highlighting that that's just some of the data that's been produced over the last few years, showing that in the ICU context, where you've got all the monitoring, where you've got all the support, respiratory support, fluid overload is associated with poorer outcomes, including increased mortality. And it's also worth pointing out that we've had arguments over decades about, well, do I use albumin, do I use colloids, do I use crystalloids? And people talk about osmotic gradients, and we've forgotten about the complexity of things like the glycocalyx, and it may be glycocalyceal function that determines how much fluid leaks out of the intravascular space, not necessarily what the oncotic pressure is. So perhaps it's a little bit more complex. What about transfusion? So I think people have known for a very long time that blood for transfusion carries some risk, and that relates to infection, white cell issues, antibiotics. But what we haven't highlighted is just how much blood products differ from country to country and how the quality of those products differ, and even how the preparation, the process, the storage of those products differ. And unfortunately, all of those issues have consequences for the safety of giving blood products. And just here's a series of studies. The bottom line is that, for instance, blood that has been stored for longer periods of time, even under reasonably optimal conditions of storage, which don't apply in many countries where you work, may be associated with increased morbidity, increased mortality in those patients. So if you're going to transfuse, you have to look at what you're actually going to give. But even if you have high-quality products, there's a whole set of complications that actually arise from it. So when do I actually give this stuff? So one is, I think, if you're bleeding to death, it's quite clear blood is useful. But then you've got to stop the bleeding as well. And there's a lot of increased work looking at some of the things we might be able to do to stop bleeding. And things like tranexamic acid and so on may be important if that's available. But basic things like dealing with hypothermia, stabilizing patients are important there. But when do you have to transfuse? And there's a fascinating body of literature that comes from situations where patients with Jehovah's Witnesses refuse blood transfusion. And they have some data on when does that hemoglobin or that drop in hemoglobin post-surgically actually translate into higher mortality. And it's interesting that if you look at these curves, the drop in survival happens in those patients when you get below about 5. That seems to be a point where it drops off badly. Similarly, again, if you just look at where the composite morbidity and mortality really steps up, it's when the hemoglobin starts getting around 5 and somewhere there. And if you look at some of these studies that have been published over the last few years, mainly in Kenya, somewhere around 5 seems to be the number where the mortality starts jumping up really steeply. And I think that's useful. In the ICU setting, the major data that we have and the sort of randomized control study looking at the use of either a threshold of 9 grams per deciliter or 7 grams per deciliter, and that's a TRIP ICU study. They were looking at patients who were in ICU, and this was their definition of who was stable. So not necessarily a particularly stable patient by many criteria. And if you look through the subgroup analyses from that, one is there didn't seem to be much difference between transfusing at 9 or 7. But if you transfused at 9, in general, they spent more time in hospital. If there was sepsis, again, there didn't seem to be much difference between them. If you looked at different severities of illness there, didn't seem to make much difference from them. So that data would suggest there's no benefit in using 9 rather than 7. There's other data from ICUs that looks at the amount of transfusions that patients got in ICU. What's absolutely predictable is that the more transfusions you got, the longer you stayed in ICU. And that's also true for post-operative patients. So somewhere between 5 and 7 seems to be where the sweet spot may be. But I do want to just put this data to you, and this is some data that comes from the US, from patients undergoing major surgery. And what they were comparing was the additional risk related to giving a blood transfusion relative to your underlying risk. And what they were showing is that if you were at extremely high risk of dying from the surgical procedure and what was underlying it, adding a transfusion added very little to your risk. But if you were at low risk of dying or getting into trouble from your surgery, adding some hemoglobin actually significantly increased your risk. And so the risk of the intervention also relates to the risk of dying before you actually had that intervention. And that's then the sort of protocol that has come out for pediatric intensive care units as to where the thresholds should be. And you can see that numbers such as 5 and so on come into it. But I would just, again, say that trajectory makes a difference. If you have a particular number and you're getting better, I probably won't transfuse you. But if you have the same number and you're clearly getting worse, I might think of transfusing you. And I think one needs to be taking into account not only the absolute number, the point, but what's happening to the patient over time. So I'm sorry, we have to balance complexity with pragmatism. Unfortunately, what has come out of rich countries as this is what you must do clearly does not work in poorer countries. And you know what? It may not always work in the richer countries either. You have to look to some extent at the individual risks of this patient in front of you, who may not only have dehydration or anemia or sepsis, but may have them all together mixed up in funny ways with underlying disease processes. You need to take into account the risks of giving you this therapy in your environment. What monitoring do you have where you are? What products do you have where you are? Because those affect outcomes. And you know what? I still think it's very difficult. So thank you for your attention.
Thank you very much, Andrew. Is there any quick question? One or two maximum? Do we have a microphone? Can you turn it on, please?
When it comes to elevated body temperature, fever, and the increase in oxygen demand that entails, how important do you think it is to manage an elevated body temperature?
I think the simple answer is I don't know, because at one level, I could say that decreasing temperature might decrease your metabolic requirements and may make things a little bit better. On the other hand, it does seem that you develop temperature for good reason. And actually, having the temperature helps you to fight infection better than if you don't have the infection. Clearly, if patients are struggling with severe tachycardia, with shortness of breath, there is an impression that settling them down to some extent, or bring the temperature down a little bit, may help things. But I do it cautiously, and the problem is that many of the ways in which we try and bring down temperatures by using fans, cooling, and so on, may actually make some patients extremely uncomfortable. So we do try to keep patients as comfortable as we can, using whatever they're, because that decreases their oxygen demand. I think if the temperature is very high, it makes sense to try and bring it down gently. But if you make your patient thoroughly uncomfortable, it may actually be counterproductive.
That was excellent, really great. Could I just ask about oxygen? Because giving oxygen is badly done in many low-resource settings. I mean, you know, the organization needed to get it. And yet it would seem that giving high-flow oxygen is standard in well-developed countries. So should we put more emphasis on oxygen as well in the settings we're in? Make sure that any patient who may be in this condition, this complex condition, does get high levels of oxygen, or are there any dangers for that?
So David, I'm not sure if you're deliberately setting me up, but you know, I think if you're looking at patients who are hypoxemic from pneumonia and so on, clearly giving oxygen can be life-saving, and I don't think anyone would argue with that. I think there's increasing realization that high concentrations of oxygen in a variety of contexts may do harm. And inhaling high concentrations of oxygen for extended periods of time will certainly damage the lung and other areas. And it's important to note that while nasal oxygen on an adult will probably never be able to give significant oxygen concentrations, on small infants, even 2 liters a minute can actually give a very significant FiO2. So I'd be cautious of that. I think one of the intriguing aspects, and there's work from Malawi and other parts, is that CPAP, or some distending pressure rather than high oxygen, may well be something that's useful. I know in our environment, increasingly, patients with respiratory distress related to shock, severe acidosis, those settings, are being given high flow, or that's high flow humidified oxygen or CPAP, not with high FiO2s, but with that distending pressure and flow. And many of them, we're trying to collect the data now, appear much more comfortable and settled. But there's a desperate need to say, let's collect the data, let's understand what it really does.